Okay, imagine this. You step into a busy operating room.
Right.
The stakes, they just couldn't be higher. You've got a team of surgeons, they're ready, poised to perform a life-saving organ transplant.
Critical moment.
Every single move they make, from that very first incision right through to the final stitch, is just absolutely critical.
Absolutely. There's zero room for error.
Exactly. So now, what if these surgeons, these highly skilled people, could actually practice these incredibly complex procedures?
Like over and over again.
Yeah, countless times. In like every situation you could possibly imagine.
Yeah.
All before they ever touch a real patient.
Wow. That would change everything.
That's the future, right? And that's really what we want to dive into today.
And, that future, it's pretty much already taking shape, largely thanks to virtual reality.
So yeah, this deep dive is all about how VR is, rapidly transforming how surgeons train for organ transplants.
We've pulled together insights from some really fascinating sources for you, cutting-edge research papers, academic reports, and some pretty compelling case studies. We're talking places like Lawrence Livermore National Lab, Sunway University over in Malaysia, Otto-von-Guericke University Magdeburg in Germany, and the Ochsner Clinic down in New Orleans.
Quite a lineup. So our mission for this deep dive, then, is to really unpack how VR isn't just like tweaking medical education. It feels like it's fundamentally reshaping it.
That's a good way to put it.
We're talking about giving surgeons these unprecedented chances to hone their skills, mastering super intricate anatomy, performing entire complex procedures, all inside a completely risk-free virtual world. So by the end of this, you should have a really clear picture of the absolute cutting edge of surgeon training. Hopefully some aha moments and maybe a few surprising facts along the way. Okay, let's start with an organ known for being, incredibly complex. The liver.
Oh, yeah.
Its structure makes liver surgery, particularly transplants or resections, just exceptionally challenging. It's real text, isn't it?
It absolutely is. And one of the really advanced systems trying to tackle this head-on is the collaborative laparoscopic liver surgery VR. This came out of Lawrence Livermore researchers, Shang and their team.
Okay.
What they've essentially done is build a multi-user VR training hospital. It's specifically for these complex liver resections. But the really unique part, it's the collaboration.
How so?
Well, as a trainee, you might start out in a virtual planning room. It's got this 3D organ library and imaging simulator. You can actually choose your resection lines right there.
Meticulously plan it out.
Exactly. Then you step into a full VR operating room to actually perform the laparoscopic procedure. But here's the innovation. You use physical controllers. One person, the lead surgeon, has a cutting tool while someone else operates the endoscopic camera.
Just like in a real OR team?
Precisely. And they've even built in critical teamwork scenarios. You have to communicate and coordinate with a virtual assistant, a virtual anesthesiologist, maybe deal with sudden bleeding or muscle spasms that pop up.
Wow, so real-time problem solving too.
Right. It forces that interprofessional communication. They did a pilot study at University Medical Center Mainz in Germany, and the feedback was apparently really positive. They highlighted, significant advantages over the simulators they already had.
That's impressive.
Yeah, and this work was published just recently in Computers and Graphics 2024, showing it's been validated through collaborations with Magdeburg and Mainz universities.
What really strikes me here is that it's clearly not just about one person's hand skills. It really pushes that multi-user collaborative piece. So you're not just training your hands, you're learning how to operate as a smooth, efficient team in a really high-pressure situation.
Yeah.
It feels like a huge shift.
It's a massive shift, definitely. Because surgery is a team sport, fundamentally. And speaking of collaboration, another really key piece of work that sort of underpins this is the multi-user liver anatomy VRR.
Okay.
This comes from Schott and his team at Otto-von-Guericke University Magdeburg, working with partners in Mainz. It's an immersive VR and also AR environment specifically for learning liver anatomy.
So focus on the learning part first.
Exactly. Foundational knowledge. It's built in Unity, which is a popular game engine, right? And they use photon networking, which makes it really robust for multiple users, think classroom-sized groups learning together.
Right.
At its core is this virtual organ library. It has 19 different patient-specific liver models, all derived from real CT scans. You get these interactive 3D surfaces, but also the 2D
You
slices.
can see it from all angles.
Totally. Students and instructors can view them together, they can annotate them, even virtually slice them open to really understand the segmental anatomy, and they can do this in full VR or using something like a HoloLens for augmented reality, or even just on a desktop.
Flexible.
Very. They did a user study faculty, and med students reported high usability, a strong sense of presence. They felt it potentially supports the teaching of liver anatomy and surgery. But here's the really compelling bit. Another study by Huidel and colleagues actually found that participants using this immersive VR identified liver segments more accurately and faster than people using standard 2D images or even 3D PDFs.
So a measurable learning difference.
A statistically significant one, yeah. And get this, 73% of the users actually preferred the VR interface. That tells you something about the engagement and effectiveness.
It's fascinating, isn't it? How this earlier foundational work really seems to have paved the way for these incredibly sophisticated modules we're seeing now.
Yeah.
You can almost trace the evolution.
You absolutely can. And we shouldn't forget some of the even earlier historical work, like from Maresco and his team back in 2004. They demonstrated real-time deformable liver models for simulating hepatectomy in VR.
Deformable. Wow.
Yeah. Now, it wasn't strictly for transplants, but those efforts were crucial. They showed VR's potential for complex liver surgery, letting surgeons visualize in 3D and practice actually cutting. Maresco's team even predicted back then that repeated VR practice will revolutionize surgical training.
And it looks like they were right.
It certainly seems that revolution is unfolding right now.
All right, let's shift gears a bit. From the liver to the kidney. Another vital organ, obviously, but with its own set of complexities when it comes to transplantation. Different anatomy, different challenges.
Definitely. And the kidney has seen some really, really exciting developments, especially when you bring in haptics.
Haptic, so touch feedback.
Exactly, the sense of touch. So from Sunway University in Malaysia, Lim and Yap introduced the haptic VR kidney transplant simulator just this year, 2024. It's a fully immersive VR module simulating the entire kidney transplant procedure.
The whole thing.
The whole 9 yards. It's built in Unity again, using something called the Orama VR Medges SDK. That's like a specialized toolkit to speed up building these super realistic medical simulations. It covers all the key steps, the abdominal incision, removing the donor kidney, those really delicate vascular anastomoses.
Connecting the blood vessels.
Right, connecting the renal artery and vein to the iliac vessels, and then connecting the ureter to the bladder. But what really makes it stand out is the hardware. Trainees use a standard VR headset and controllers, sure, but crucially, there is a 3D Systems touch haptic stylus mapped to the virtual scalpel.
Oh, okay.
And this stylus gives you tactile feedback. It uses these clever physics models, they call it spring damper rendering, to mimic the resistance, even the distinct pop-through feeling you get when you cut or suture real tissue.
That sounds incredibly realistic.
Apparently it is. They did a pilot study with 4 medically trained participants, and the feedback surveys were pretty clear. The haptic feedback massively enhanced the realism and the whole training experience. Lim and Yap concluded pretty confidently that integrating haptics really improves the overall effectiveness and realism, leading to better skill acquisition and preparedness.
That's just incredible. So it's moving beyond just practice, isn't it? It feels like we're talking about VR having a direct impact on patient outcomes, maybe even expanding what surgeons can actually attempt.
That's exactly where it gets really exciting. It's the real game changer. There's this fantastic case of VR for donor kidney evaluation from the Ochsner Clinic in New Orleans. Sladen and his team published this in 2022.
Okay, what happened there?
So transplant surgeons used a VR system specifically for preoperative assessment. They were looking at a living donor with really complex kidney anatomy. They took the patient's specific CTA scans, that's computed tomography angiography, great for seeing blood vessels, segmented them into a detailed 3D model, and then explored it in an immersive stereoscopic VR environment.
They could walk around the virtual kidney, essentially.
Kind of, yeah. Really get inside the anatomy. And here's the amazing part. In one specific case they published, this donor had numerous renal arteries and veins. On the standard 2D CT scans, it looked, quote, prohibitive.
Meaning too risky, they couldn't do the donation.
Exactly. It led to an initial rejection. But then the surgical team explored that same complex anatomy in immersive VR. being able to truly understand the spatial relationships, how everything connected.
They saw it differently.
Completely. That initial rejection overturned. They decided the donor's anatomy was actually acceptable and approved them for donation.
Wow. That's not just training, that's changing lives directly.
It really is. It shows how VR can potentially expand the pool of viable organ donors by overcoming the limitations of just looking at flat 2D images. It helps make sense of complex 3D reality. And of course, it highlights VR's potential as an amazing educational tool for residents learning about these tricky anatomies. And it's worth adding, too, there was a broad review in April 2024 looking at emerging VR in kidney transplant education. It basically outlined VR's huge potential across the whole transplant journey, educating patients, planning surgeries, simulation. Now, it did acknowledge that a 2022 review found no published VR simulators specifically for transplant skills at that time, but
The things are moving fast.
exactly. New projects like that Sunway haptic system we just talked about are actively filling that gap. We're likely to see a lot more development very soon.
It's genuinely fascinating to sort of peek behind the curtain at the how. All this virtual magic happening must rely on some pretty sophisticated tech. What's actually making these simulations tick?
Yeah, that's a great question because the tech stack underneath is really what makes it all possible. First off, game engines. They're absolutely fundamental.
Like the engines used for video games.
Exactly the same idea, often the same software. Unity is super common. We saw it in the Sunway, Magdeburg, and Lawrence Livermore examples. It gets chosen because it has great built-in support for VR and tools for rapid development, letting teams create these realistic virtual worlds relatively efficiently.
Makes sense.
And things like Photon Unity networking, which Magdeburg used, that enabled their multi-user VR, letting whole classes learn together collaboratively. LLNLs, collaborative, or are likely used Unity or something similar, like Unreal Engine, for those synchronized environments. Then there's the VRR hardware. We're mostly seeing standard commercial VR headsets, Oculus Quest, HTC Vive, for that fully immersive view.
Stuff people might even have at home.
Some of it, yeah. But the Magdeburg group also cleverly supported Microsoft HoloLens for an augmented reality mode. So you could overlay virtual organs onto the real world in a teaching setting.
Cool.
LNL took it further, integrating the headsets with specialized physical controllers, like a real laparoscopic tool handle for the surgeon, and a precise stylus for the camera operator to mimic the feel of the actual instruments.
Bridging the virtual and physical.
Right. And Sunway's kidney module, as we mentioned, used an Oculus headset, but paired it with a standard VR wand in one hand and that specialized haptic stylus in the other. And speaking of haptics, that 3D Systems Touch device, it used to be called the Sensible Phantom Omni. That's a really key bit of kit in the kidney simulator.
The touch feedback thing.
That's the one. It provides that crucial force feedback. It renders the feeling of resistance, those little pop-through forces when you make an incision. It does this using pretty complex spring damper physics models. The aim is authentic tactile sensation.
Which made a big difference, apparently.
Huge difference, according to the feedback. Now, haptics weren't maybe the main focus in the liver modules we discussed. Those seemed more about the visual and cooperative aspects. But for the kidney simulator, adding that tactile layer was a major enhancement for immersion and realism. Now, where does the 3D content come from? Often it starts with real patient imaging, high-resolution CT or MRI scans.
Okay.
These scans get meticulously processed, segmented to generate the detailed 3D models you see in VR. Many projects build up libraries of different cases. SCHOT's Liver VR, for example, had 19 different patient-derived models.
It's like a variety.
Exactly. Both Ochsner and Magdeburg rely heavily on segmented CT data. And some of the really advanced systems, like the one from LNL, even let surgeons upload a specific patient's anatomy for personalized pre-op planning. And finally, that networking and collaboration piece, that's enabled by frameworks like Photon, which we mentioned, or sometimes custom-built solutions. These frameworks are what allow multi-user VR. They let trainees and instructors share the same virtual OR or anatomy lab, even if they're in different physical locations.
So remote training is possible.
Absolutely. LLNL's virtual hospital concept used a synchronized game state. That means everyone participating remotely saw the exact same patient vitals, the same virtual environment, ensuring a truly collaborative and consistent training session.
It's incredible to hear about all the engineering involved, but, at the end of the day, these really sophisticated tools exist for a reason. What are they actually designed to teach? And more importantly, what kind of results are they seeing? What are the educational outcomes?
Right, because that's where the rubber meets the road. Beyond just the cool technology, a huge goal is boosting anatomical comprehension.
Understanding the body's layout in 3D.
Precisely. And studies consistently show immersive VR really helps with that. Take the Hoyle study again. Surgeons and trainees identified liver segments more accurately and faster in VR compared to looking at 2D PDFs. Most just preferred VR because it turns flat images into something tangible, something you can interact with.
You internalize it better.
Seems so. SHOT's VR environment is explicitly designed to teach liver anatomy and team planning using tools like virtual slice planes, labels, diagnostic overlays. It allows for virtual dissection. We consistently see reports of improved 3D anatomical orientation, like finding tumors faster, which is obviously critical in surgery. Then, beyond anatomy, there's the technical skill simulation. The Sunway Kidney Simulator lets trainees practice very specific skills, like suturing tiny vessels, anastomosis.
Things that require real dexterity.
Absolutely. And the key is repetition. You can practice those steps: incision, applying clamps, sewing the graft over and over again, building muscle memory without any risk whatsoever to a patient. The participants in that study rated the VR suturing with haptics as highly realistic. They said the force feedback made cutting and stapling feel authentic.
Like the real deal.
Pretty close. And similarly, the LLNL laparoscopic system trains that fine motor coordination, guiding virtual cameras and instruments, often under simulated stress, like bleeding or time pressure. That improves psychomotor skills and teamwork, things that are really hard to practice outside of a real operating room. Another crucial area is teamwork and decision-making. The more advanced VR scenarios actually incorporate the wider surgical team. That's something traditional training often struggles with.
Simulating the whole OR dynamic.
Exactly. Chang's multi-user platform, for instance, requires you to talk to a virtual anesthesiologist to manage, say, simulated low blood pressure or muscle spasms. The aim is to simulate the whole headspace of surgery, not just your individual technique, but how you respond to a crisis, how you coordinate with everyone else.
That sounds invaluable.
And the early user feedback suggests trainees really appreciate these collaborative features, because those are often the skills that break down first under pressure in a real OR. These tools also foster planning and critical thinking. Simulating complex cases helps develop those essential preoperative planning skills. Trainees can virtually rehearse procedures on unusual anatomies beforehand.
Like the Ochsner case.
Perfect example. That showed how 3D VR helped the team reevaluate those complex donor vessels, a critical life-changing planning decision. In other educational trials, surgeons use VR to choose the best surgical approach by really inspecting the anatomy from every angle, getting a level of spatial understanding that's just tough to get from 2D scans alone. And finally, measured outcomes. How do we know it works? Well, validation is definitely emerging. SHOT's study showed positive usability and presence scores, suggesting people felt immersed and engaged. The Sunway team used Likert scales, finding unanimous agreement that haptics significantly improved learning and realism. The LLNL pilot in Mainz got generally positive feedback from experts who noted their VR system actually outperformed other simulators they had for complex laparoscopic skills.
So good signs, but maybe not large-scale trials yet.
Right. Large-scale, randomized controlled trials are still somewhat limited, but the initial evidence we have strongly suggests these VR modules enhance both knowledge and user satisfaction. It's really laying the groundwork for more definitive studies down the line.
That's all very promising. But, the key question remains, how do we really know these systems are effective beyond the initial excitement? What's the sort of concrete proof of their impact so far?
That's the crucial question, absolutely. And you're right, most projects are still technically in pilot or prototype phases, but we do have some compelling early validation points.
Okay, like what?
Well, take the Sunway Kidney VR. It was a small test, just 4 participants, but they used detailed surveys. Every single one agreed that the haptic VR felt more engaging and more realistic than a version without haptics. Based on that, the authors felt confident, concluding that these systems could indeed help produce competent and confident surgeons through that realistic, repetitive practice. Then there's the Magdeburg Liver Anatomy VR. They did an experimental evaluation with 5 instructors and 5 students using questionnaires. The results showed high usability, a strong sense of being present in the virtual environment, and the users generally felt it would really help future anatomy training, mainly because of that unique 3D visualization.
So more qualitative feedback there.
Mostly, yes. While they didn't focus heavily on objective test scores in that particular study, the qualitative feedback was definitely overwhelmingly positive. For the LLNL liver surgery VR, that pilot study they ran at Mainz involved actual surgeons and residents. They found the system was technically sound, feasible to use, and importantly, they noted its significant advantages over older 2D training tools. They preferred it for its immersive, collaborative feel.
Strong endorsement from the users.
Very strong. Though the study authors themselves rightly stress that more extensive clinical trials are still needed to fully nail down the long-term training benefits. And then you have the Ochsner VR planning case. Now, it's a single case report, so it's anecdotal evidence, but it's incredibly powerful real-world evidence.
The kidney donor one.
Exactly. It directly showed VR facilitated decision-making, and crucially, it directly changed a major clinical outcome, getting that kidney donor approved, who would otherwise have been rejected based just on the 2D scans. You can't argue with that kind of direct impact on a life. And importantly, we do have some comparative studies, like the one by Weddle in 2021 we mentioned earlier. That was controlled. It directly compared VR versus non-VR methods for identifying liver segments.
And VR came out on top.
It did. Participants using VR named more segments correctly, and they did it faster. That's significant because it directly supports VR's ability to improve spatial understanding, which is just fundamental for a surgeon. So to sum it up, the published results so far, overwhelmingly positive, yes, but often based on these early studies, smaller user groups. It is true that a 2022 systematic review pointed out that at that time there weren't many VR simulators specifically for transplant skills reported widely in the literature.
But that's changing now.
It absolutely is. As we've seen, these new modules from places like Sunway and LLNL are actively filling that exact gap. We can definitely expect much more comprehensive validation. Think full curriculum integration trials, detailed performance metrics to start emerging probably within the next few years.
It's also clear these projects aren't just, dreamed up in isolation in some lab. They obviously require huge amounts of collaboration to come to life. How are these cutting-edge ideas actually making their way out of research and into real medical training programs?
Yeah, that collaboration piece is absolutely key to their success. The Lawrence Livermore team, Cheng's group, is a prime example. They worked incredibly closely with the University Medical Center Mainz and also Otto-von-Guericke University Magdeburg in Germany.
Right, the clinical partners?
Exactly. The Mainz Transplant Center wasn't just a research partner. They were actively trialing the VR system, giving that crucial clinical feedback. That's essential to make sure these tools are medically realistic and actually practical to use. And beyond those specific partnerships, we're seeing integration with academic hospitals more generally. That LANL platform, for instance, is already being used right in a real hospital OR setting, with volunteers for now, but still, it's happening at Mainz. Sunway's group, although based at a university, is actively planning collaborations with local hospitals. They need that direct surgeon input as they develop things further. These systems are also clearly designed to feed directly into surgical training programs. Think about the Ochsner VR case that involved transplant surgeons, a whole multidisciplinary donor committee. It shows VR being woven into the actual clinical workflow for real patient decisions. These tools are definitely being positioned as vital additions to formal fellowships and residencies, enhancing the traditional training pathway by offering practice opportunities that just weren't possible before. And none of this would really work without genuinely interdisciplinary teams. These aren't just projects run by doctors or just by computer scientists. They span computer science, engineering, and medical faculties.
Bringing different expertise together.
Absolutely. Schott's team in Magdeburg combined VR researchers with experienced surgeons from Mainz. LLNL's project had computer scientists working side by side with clinical experts from transplant surgery and anesthesiology. That kind of cross-disciplinary work is fundamental to ensure both the technical sophistication and the vital medical realism these advanced simulators need.
Wow, what an incredible journey we've just taken through this technology. It really feels like VR is fundamentally changing how surgeons prepare for these incredibly high-stakes procedures. It's offering not just practice, but maybe precision practice without the peril.
That sums it up perfectly. These VR modules, they really are much more than just simple simulations anymore. They feel like a genuine new frontier in surgical training. You've got this sophisticated integration of haptics, seamless multi-user collaboration, the ability to use patient-specific data. It all goes so far beyond traditional methods. And the promise, ultimately, is safer surgeries, better patient outcomes. Because surgeons can master these incredibly complex skills, hone their critical thinking, all in a completely risk-free environment. They can prepare for exactly what they're going to find inside a specific patient.
It really leaves you with a thought, doesn't it?
Yeah.
What if the future of personalized medicine isn't just about tailoring the treatments to your unique biology, but maybe also about tailoring the surgical training to each specific patient's unique anatomy before that first incision is even made.